All right, today we're going to take a look at a couple projections of the thoracic spine. We have two common projections, the AP and the lateral, also with an additional projection called the swimmers. Now, do note we mentioned the swimmers in the cervical spine projections list, and I just put it on here for convenience. The swimmers is almost always used with the thoracic spine, but also used very commonly with a cervical spine due to the fact that visualization of C7-T1 interspace is usually obstructed due to the broadness and thickness of patient's shoulders, the area where the humerus is very, very dense. So here we have the AP lateral and swimmer's T-spine. As we take a look at the AP T-spine, notice the top of the light field is approximately 1.5 to 2 inches above the patient's shoulders. Tight collimation has ensued, and we want to leave the collimation from top to bottom open as much as possible. Typically 17 inches is adequate to get both T1 through T12. Notice the right marker placement can be snuck in right up there at the top. And let's take a look at what our image will produce. All right, for this we have a nice countdown. We have the very first vertebrae starting right here with the rib attachment that comes around that's nice and curved. That is the first rib. So as we count here, we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. Additionally, we can look and we see that the lumbar vertebrae number 1 does not have that rib attachment. So due to this particular patient, we get to visualize all 12 with the AP thoracic spine. As far as respiration phase goes, that can vary from site to site protocol. Some places choose to do at the end of inspiration, while some choose to do at the end of expiration. Now let's take a look at our lateral T-spine. As we look at this, we basically will treat this very similar to a chest x-ray or a lateral chest x-ray, where we'll have the patient turn into a true lateral. You want to have the arms nice and elevated, and there shouldn't be much change in the central ray entrance point. We are looking at theoretically around the level of T7. Some people might want to palpate on the back of the scapula and find the inferior border of the scapula. Also, some people will use a reference of approximately 3 to 4 inches below the axillary region. Typically, I just leave my central ray exactly where it was with the AP and turn the patient into a true lateral. And if we got the AP, we will most certainly get the lateral as well. Once again, it's very imperative that we collimate from front to back here. We want to reduce as much scatter radiation as possible and leave our collimation from top to bottom open. Now, as far as our breathing techniques, those also will vary from site to site. With some of the digital radiography now, we can get a very crisp, clear picture on inspiration, and we can see down as far as possible. There's also the breathing technique where you have a longer exposure, typically 4 seconds of exposure with a same adequate mask that you would normally use, and that longer exposure will blur out the ribs and get good detail on the spine that we're looking at. Now as we take a look at the swimmers, once again, position is very similar to a true lateral. However, in this particular case, you want to elevate the arm closest to the IR, depress the right shoulder, or the one furthest from the IR if possible. And if that's not something that you're able to do, you'll want to throw a caudal angulation on of approximately 3 to 5 degrees. You'll want to enter that space right around the level of T7, T1, and you'll want to collimate down here. You want to make sure that you can get adequate penetration to that C7-T1 interspace as we see here in this projection. And there you have it, the 3 common views of the thoracic spine.